Bismillahirrahmanirrahim. Assalamu alaikum and good morning. Department of Dermatology welcomes all the participants today for the 16th Dermatology CPC hosted by the Dow International Medical College, Dow University of Health Sciences, in collaboration with Pakistan Association of Dermatologists, who are always very eager for every academic activity. Thank you so much. And the social networking will be taken care of by Brooks Pharma, who will be responsible for smooth networking. So we have 3 interesting cases lined up. And without further delay, I would like to invite Dr. Uroosa to present her first case, and then we will proceed on. Thank you.
Assalamu alaikum and good morning to you all. I am Dr. Uroosa Shafiq, working as FCPS resident dermatology at Dow University Hospital. Today, I am going to present a first interesting case of today's CPC of about a 11-year-old girl student resident of Hunza with no known comos presented in our OPD on 22nd of January 2024 with the presenting complaint of fluid-filled lesions on body since the age of 1.5 years. According to the attendant of patient, she was in her usual state of health 1.5 years after birth when the child started having fluid-filled lesions on the hands and feet. The lesion was associated with itching followed by redness. Within few months, these lesions progressed to involve the face, neck, and feet. Later, the mother noticed skin fragility with slight trauma. The lesion was filled with serous fluid, seldomly with blood, ruptured spontaneously within 3 to 4 days, leading to crust formation and healed with scarring. The lesion was aggravated by dry and hot climate. The lesion waxed and went but never completely cleared, and she also complained of tightening of skin of hands and face along with dyspigmentation. She also had a history of photosensitivity and arthralgia, and there was decrease in the severity as she progressed in age. No history of oral ulcer, fever, or any deformity, and there is no history of darkening of urine or nappy staining. Systemic review was unremarkable, except in musculoskeletal system, she had a history of arthralgia on and off, which were primarily involving the knee and elbow joints. Past medical and surgical history, she went to multiple pediatricians and dermatologists for this complaint, but only temporary relief was provided. Birth history, she was born at full term through spontaneous vaginal delivery. She was completely immunized according to the attendant, but no record was available. She achieved all her developmental milestones on time. On personal history was unremarkable, and history of weight loss was not documented, and she was not addicted to anything. At the time of presentation, her dermatology life quality of index score was 12. Family history, she has 3 siblings, all healthy and alive. Her parents have consensuous marriage. Both her parents were normal and healthy, no history of any chronic illness or similar disease in the immediate family. But they were not sure about the distant family members. Drug history, only use of various topical medication, but no record was found, and no drug allergy history was available. No history of any blood transfusion. She belongs to middle class family and sanitary condition was satisfactory. Before we proceed to examination, I would like to add here that these pictures have been shared with the consent of the patient's family. On general physical examination, a young female of good height and build, sitting comfortably on chair, well oriented to time, place, and person. She was vitally stable at the time of examination, and sub-vitals were negative. Thyroid and lymph nodes were not palpable. On cutaneous examination, the patient had multiple vesicles and erosions with erythematous background and hemorrhagic crusting distributed over the dorsum of her hands and feet with a varied number of milia and scarring, as you can appreciate in these pictures. On examination of face, there is perioral furrowing with normal mouth opening, and erythematous scaly plaque of 1 by 1 centimeter on the corner of the mouth was also appreciated. There is yellowish brown discoloration of teeth, and other oral examination was unremarkable. Few crusted regions were evident on left nasal side wall medially, and multiple areas of atrophic scarring with hyperpigmentation and hypopigmentation on face was also noted. There was hypertrichosis evident on the forehead, temple, and cheek. As you can see in these pictures, evident hypertrichosis. And on examination of neck, area of hyperpigmentation and hypopigmentation with scarring on the back of the neck was also seen. Examination of other like nasal mucosa, nails, and genitals were unremarkable. Systemic examination was also unremarkable. So case summary of my patient is 11-year-old female patient, resident of Hunza, no known comorbids, presented with complaint of fluid-filled lesions on body since the age of 1.5 years. On cutaneous examination, the patient had multiple vesicles and erosions with erythematous background and hemorrhagic crusting distributed over the dorsum of her hands and feet with a varied number of milia and scarring. Perioral furrowing with normal mouth opening, yellowish brown discoloration of teeth, multiple areas of atrophic scarring with dyspigmentation on face, and there was hypertrichosis evident on the forehead, temple, and cheeks. These are the pictures of my patient, and keeping the history and clinical examination in our mind, our differentials were congenital erythropoietic porphyria, Porphyria cutanea tarda, Hydroa vacciniformis, generalized intermediate epidermolysis bullosa, and epidermolysis bullosa equista. So to rule out the final diagnosis, we did some baseline investigations in which CBC came out to be normal and ESR was mildly raised. Creatinine was within normal range. LFTs was within normal range. Hepatitis B and C serology was negative, and serum ferritin level was also within normal limit. Ultrasound of abdomen was performed, which was normal. As she was giving a history of severe photosensitivity, and we did serum vitamin D level, which was 8 nanogram per milliliter, and she falls in severe insufficient level. Because she was giving a history of photosensitivity and blister formation, we did ANA profile to rule out possible connective tissue disorders, and ANA profile was negative. We did Woods lamp examination, which shows erythrodontia and pink fluorescence of urine. We also performed skin punch biopsy, which reveals subepidermal blisters with sparse inflammation, dermal papillae projecting into the blister cavity, that is festooning. Direct immunofluorescence was also done, which shows IgG positive at basement membrane, IgA, IgM, and C1q was negative. C3 was weak positive at basement membrane plus blood vessels. So based on the history, clinical examination, and clinical tests, we established a diagnosis of Porphyria cutanea tarda. However, we wanted to confirm it with porphyrin studies and gene analysis, but unfortunately, neither were available. We contacted all the possible centers in Karachi and in Pakistan, but it was not happening in Karachi. So we made a diagnosis of Porphyria cutanea tarda and started the treatment. And Alhamdulillah, the patient responded very well with the treatment. We manage the patient by advising sun protection using sunblock and protective clothing. Whenever she goes out, we advise her to wear long sleeves, gloves, and use hat, cap, and umbrella. We started the specific treatment, that is tablet hydroxychloroquine 200 mg once weekly after ophthalmological examination, and tablet ascorbic acid 500 mg once daily was also given. As she falls in severe insufficient level, we replaced vitamin D level according to her age. These are the follow-up pictures after 1 month, and you can see the lesions were completely resolved, and after follow-up, her dermatology life quality of index score was 4. Now, I would like to share some case reports with you all. This is a case report of Porphyria cutanea tarda, which was published in Indian Journal in 2022, in which an elderly patient presented with the similar cutaneous finding, although the age was not in our favor, but they did Woods lamp examination, which shows pink fluorescence of urine and teeth. Here is another case report of Porphyria cutanea tarda, which was also published in Indian Journal in 2018, and 14-year-old girl presented with the same cutaneous findings, and similar Woods lamp finding was appreciated. This is another case report of Porphyria cutanea tarda, which shows Woods lamp examination revealed a bright pink fluorescence of urine. And you can have many more cases of similar Woodslam finding and cutaneous examination. Although the Woodslam finding was not written in our textbook, but we reviewed multiple literatures, which shows that Woodslam finding of erythrodontia and peak fluorescence of urine is a feature of Porphyria cutanea tarda. Now, a brief discussion about the cutaneous porphyria. Cutaneous porphyria is a group of inherited or acquired disorders caused by defects in the biosynthesis of heme. Porphyria cutanea tarda is a commonest porphyria, and it is due to deficiency of uroporphyrinogen decarboxylase, in which there is accumulation of uroporphyrin and highly carboxylated porphyrins. It is usually acquired, and patient presented with the similar clinical features which we have already discussed more or less, and it has an association with liver disease. Biochemical findings of Porphyria cutanea tarda in urine shows uroporphyrin level 3, and in feces shows isocorpoporphyrin levels. So our take-home message is everyone should have a Woodslam in her OPD, in her or his OPD, as it is a small or painless tool that can identify a certain medical condition that multiple doctors can forget to use it. So it is important. It is interestingly important to make it known to as many people as possible. Thank you. Now I would like to invite Dr. Sadaf to come and give her remarks.
Yeah. Thank you, Dr. Uroosa. Okay, seems like an interestingly simple case, right? But looking at the patient's journey over a period of 9 to 10 years, where she has been visiting multiple doctors, specialists in different hospitals, different cities, traveling from one city to the other, and eventually ending up after such a long time over here with the query of what is wrong with her, what is her problem, what is her disease? Is it a disease or is it a curse? So basically, we addressed them one by one. We told her what we thought, how we would go step by step ahead, and what we required, and how would we help establish the diagnosis and further improve her quality of life as well. So keeping all this in mind, the patient and the family was very cooperative. They understood, and they understood it is an inherited disorder. And basically, we always emphasize on history and examination as being the crux of a diagnosis. Always practice it as well. And Wood's light examination is very simple and basically present in every department, everywhere nationwide, and it should be utilized. That was the basic punch that we were trying to get, that whatever is available, we should utilize that. It directs us in the proper direction. Just as it happened in our case, erythrodontia and fluorescence of the urine were one of the clues which just directed us as to where we had to proceed. And it helped the patient, the family, and led to smiles on their face and improved her quality of life. And that is what we strive, what we seek to achieve always. So basically, the idea is whatever is available, you should try to grab those and utilize them to the maximum for patient benefit and for your own learning process as well. Now we would move on to the second case, which is by Dr. Eraj.
Thank you, Dr. Sadaf, for inviting me. Assalamu alaikum. My name is Dr. Eraj Aman. I am FCPS PG Dermatology at Dow International Hospital. I'm going to present a case of 8-year-old female. She's a resident of Karachi and she has no known tumor presented to us on 31st of August 2023. With a presenting complaint of generalized redness and scaly lesion all over her body since the 3rd day of birth, along with skin-colored papules on a scalp, back, and buttocks for last month. Coming to the HOPC, according to her mother, she was in a usual state of health after 3 days of birth when she started getting generalized erythema along with scaling over her trunk. This progressed to involve the other areas of body such as the face, neck, abdomen, upper and lower limb. Later, the mother noticed a similar rash on the diaper area as well. After a few months, the erythematous rash settled down and it evolved into desquamated patches. There was history of irritability of the child was probably because of the itching. The lesions were aggravated by dry and hot climate and it partially improved with the use of emollients. For the last 8 years, the lesion waxed and waned, but never completely cleared and associated with severe itching. There is also eruption of skin-colored papules, which started 1 year back with rough, irregular, and hard surface. It was asymptomatic and present on the lower back, buttock, and scalp, and increasing in number with the time. She also had history of recurrent allergic rhinitis since infancy, but there is no history of any lower respiratory tract infection or GI tract infection. No history of loose stool, abdominal pain, photosensitivity, behavioral changes, or weight loss. Coming to the systemic review, all her systemic review was unremarkable except that she had history of recurrent allergic rhinitis along with short stitching. In the birth history, she was born at full term via cesarean section and is product of consensuous marriage. She was born without a colloidal membrane and her mother had an uneventful pregnancy and delivery. Her parents were first-degree cousins. In her past medical and surgical history, she went to multiple pediatrician and dermatologists, but only temporary relief was provided. She has complete immunization history, but there was no record available. In the developmental history, she achieved all her milestones on time. Her personal history was also unremarkable. In family history, she has 2 siblings, an elder brother of 10 years and a younger brother of 2 years. Elder one has similar complaint as my patient, and both her parents were completely normal and happy. But 2 of her paternal uncle had similar history of itchy condition, and one of the uncle investigated in detail from a government hospital, and he was being diagnosed as mucopolysaccharidosis on the basis of skin biopsy. In the drug history, she has used multiple emollients, scabicidal agent, topical antifungals, and topical steroid, but there was no history of any allergy to medication. In the socioeconomic history, she belongs to lower middle class family. The only bread earner is her father, who lives in Saudi Arabia with her grandmother. They live in their own house of 2 rooms, which was well ventilated and sanitary condition was satisfactory. Patient was homeschooling since childhood. She drank unboiled water and there is no pet at home. Now coming to the examination, general physical examination, my patient was young, she was active, alert and short with normal intelligence and wearing spectacles. Her height was 89 centimeters and her weight was 20 kgs. Height for age percentile was below 5 and her weight for age percentile was below 3rd percentile. Her vitals and subvitals were all normal. Before starting the cutaneous examination, I would like to inform you all that all the picture taken from the patient was taken with the consent of her mother and father. On cutaneous examination, her skin was overall dry and scaly with eczematous plaques present all over her body. On the trunk, there were widespread eczematous plaque along with excoriation on the chest and abdomen. Erythema and desquamation were also prominent on the abdomen, as you can see in the picture. Now on the back, there were widespread erythematous papulosquamous plaque with fine white scaling. And there was also multiple warts present on the buttock and lower back as well. In the lower limb, there were annular, serpentinous, and erythematous plaque with prominent fine trailing scale evident diffusely present all over our legs and buttocks, as you can clearly see in the picture. Similar rash was also present on the upper limb along with some yellow-brown crusted plaques on the extensor surface of the forearm. On the face, eczematous lesions were involving the eyelids, forehead, eyebrow, and perioral area. There were erythematous fissuring and crusting on the oral commissure, along with hypertrichosis that was evident on the forehead and temple. In this picture, you can see behind the ear and also the side of the face. On the scalp, Hairs appear dry, short, dull, and brittle. There were multiple warts of variable sizes on his scalp, mostly populated on the vertex and occipital region. In the eye examination, we did the detailed eye examination, and eyes shows erythema and crusting, especially over the lashes and lid margin. Visual acuity assessment and slit lamp examination was also done, and it showed myopia with no corneal clouding on examination. Her examination of oral cavity, nasal mucosa, and nails were all unremarked. Her systemic examination was also normal. Now, the case summary of my patient, who is an 8-year-old female child, present with a complaint of generalized redness and scaly lesion all over her body since the third day of birth, along with some papular eruption since last 1 year. And these scaly red lesions settle down and transform into the desquamated patches after a year, and then aggravated. There is episodic aggravation with hot and dry climate and severe itching. There's also a history of allergic rhinitis and short stature. There's positive family history of similar complaint as well. On the examination, her skin was dry and scaly with eczematous plaque present on the trunk, along with some annular serpiginous erythematous plaque with prominent fine trailing scale present on the arms, legs, and buttocks. Hair was short, dry, dull, and brittle, and there were multiple warts on the scalp, back, and buttock. Now, these are a few of the pictures of my patient. On the forearms, legs, there were annular plaques with the trailing scales. And on the face, you can see the eczematous plaque as well. Now, coming to the differential diagnosis based on the detailed history we take and the clinical finding we found on the examination, we shortlisted the differential diagnosis into hyper IgE syndrome, Netherton syndrome, Aman syndrome, seborrheic dermatitis, severe combined immunodeficiency, and down the list, mucopolysaccharidosis and extensive tinea corporis. Now, we investigated the patient thoroughly. Some of the investigation was brought by the patient, which was done from a government hospital, including the CPC. CPC showed hemoglobin of 10.5, while the TLC was 13 and a platelet of 281,000. Her differentials were, neutrophils were 68, lymphocyte was also normal with, it was 28, but the eosinophil count was raised and it was 15. UC was also done and it was normal. Her thyroid profile was done and it showed a TSH level of 7.9, which was high, and along with it, free T3 level was also high and it was 5.09. While the free T4 was normal, and the thyroid profile was suggestive of subclinical hypothyroidism. Anti-TTG, IgA, and IgG was also done previously, and it was negative. Ultrasound abdomen was done, and it was normal. Her growth hormone assay was done, and the total point was less than 5, which suggests severe deficiency. Her karyotyping was done to see the chromosomal analysis, and it was also normal. A skeletal survey showed retarded bone age, along with the reference in standard that matches to a 4.5 years old baby. Now, these are the investigations that we ordered upon coming of the patient to our OPD, including the fungal smear and culture, as the patient was having annular itchy plaque for last many years. So it was negative. Serum vitamin D level was also done because of the short stature, and it came out to be insufficient. It was 21 nanogram per ml. Chest X-ray was done to see the pulmonary findings, but it was not. Now, after doing all the non-invasive investigation, we come to a very important investigation that can help in making our diagnosis. That is histopathology. So we took the sample from her right thigh, and the histopathology was suggestive of spongiotic dermatitis. At this point, considering the patient's detailed history, clinical findings, and the lab that we have done, and the lab that the patient presents with, we consulted two immunologists here in the at the University Hospital, and she advised some workup. And with the help of immunologists, senior immunologists from the Indus Hospital, the workup was facilitated as the patient's attendance were non-affording, and for which we are very, very grateful to the Indus Hospital. Including the anti-TPO IgG, anti-thyroglobulin IgG, and anti-TSH receptor antibody IgG titers, these were all negative, which rules out autoimmune thyroiditis. Her immunoglobulin levels were also done, which came out to be within the normal range, except that IgE was markedly raised and it was 21,243 grams per liter. Her anti-PCP IgG, anti-diphtheria toxoid and tetanus toxoid titer was also done. Tetanus toxoid titer was sufficient, although the diphtheria and PCP titer was insufficient, which showing insufficient protection against the vaccination she took in the child. After that, flow cytometry was also done, which showed normal lymphocyte subset, but there was NK cells on the reduced level. Now, after doing detailed investigation, we shortlisted our differential diagnosis by excluding first the extensive tinea corporic and seborrheic dermatitis, as there is prolonged history and the investigation we have done. Then excluding the Omen syndrome as this is a life-threatening condition, and usually a patient presents in infancy with failure to thrive condition. Excluding the severe combined immunodeficiency as the flow cytometry was within a normal range, except that the NK cells was good. Mucopolysaccharidosis was also ruled out. Left with the Netherton syndrome and hyper IgE syndrome. To conclude our diagnosis, we performed trichoscopy on our patient. The trichoscopy was done on the eyebrow. Here's from the eyebrow, and it shows trichorexis invaginata or nodules. So on the basis of detailed clinical examination, history, and investigation, we conclude the diagnosis of Netherton syndrome. In the management, detailed counseling was done firstly, along with the prescription of emollients with mild topical steroids on the eczematous plaque and moisturizing wash. Oral antihistamine was prescribed along with some multivitamin zinc sulfate syrup and serum calcium and vitamin D supplements. Polymyxin bisulfate and macitrazine zinc ointment was advised to apply around the lips. Multiple sessions of cryotherapy and electrocautery was done for the warts, but recurrence within weeks or two was seen. In the follow-up, spontaneous resolution of wart was noticed after the discontinuation of treatment within 6 months. Endocrinology review was also done, and they also labeled it as subclinical hypothyroidism, and there is no need of treatment at the moment. There is plan to give injection sinatropin 0.3 milligram per day subcutaneously and advised to continue lifelong symptomatic treatment. These were our follow-up pictures after application of emollients, mild topical steroids, and supplementations. There is marked improvement seen on the body of the patient. Here are a few case reports with the Netherton syndrome associated with growth hormone deficiency. It was from pediatric dermatology, and they have a case series of 3 patients. 2 patients were twin, 6-year-old twins who presented at the age of 6 years, and they were having growth hormone deficiency, and they started on growth hormone at the age of 6.5 years, and they showed marked improvement after the initiation of growth hormone supplements. The next case was of another patient of 12.5 years. He was also started on growth hormone deficiency, and there was also improvement in the skin lesion of these patients as well. Another case report in which a neonate with possible growth hormone deficiency and transient hyperandrogenism was taken. Now, a very brief discussion on the Netherton syndrome, which is a very rare autosomal recessive genodermatosis, and it has a triad of congenital ichthyosis in which there is usually erythroderma in the infancy, and in 90% of patients, this evolved into a milder phenotype with the age and presents with the characteristic rash of ichthyosis linearis subcutaneous, along with the hair shaft abnormalities that can include trichorexis invaginata, biliary torti, or nodules, and severe atopic diastasis. There is a mutation in the SPINK5 gene, which encodes the LEKTI inhibitor, which is very important for the serine protease activity. And when there is reduction in the serine protease inhibitor activity, there is a compromised skin barrier, and there is increased chances of infection. In the investigation, we can do the microscopic examination of the hair, usually leads to rapid diagnosis, such as we can see the trichorexis invaginator or nodosa. We can also do the histology and LEKTI immunohistochemistry. Along with it, we can also go for genetic testing for the mutation in the SPIN5 gene. In the histology, we can see psoriasiform dermatitis, and along with it, there can be artifactual subcorneal or intracorneal separation, which can be consistent or diagnostically useful hint. In this picture, you can see on the picture on the left is of normal individual. It is showing LEKTI normal expression in the granular layer. And the picture on the right is of patient with Netherton syndrome, where there is no expression of LEKTI. There is no specific management for Netherton syndrome. The goal is only to manage the symptoms and prevent the skin infection. Advised to apply emollients and ointments such as paraffin-based ointment with the 50-50 white soft paraffin and liquid paraffin. Prevention of recurrent infection, and if there is recurrence infection occurrence, then antibiotic treatment along with antiseptics. Topical steroid only used for a short period of time, and if the patient is not responding to topical steroid, we can also give immunomodulators and topical calcipotriol. We can also go for UV therapy to relieve the pruritus. Intravenous immunoglobulin is kept for patient with severe condition, usually in children with initial failure to thrive condition. Infliximab can be given also in severe form, and growth hormone therapy in those patients who have growth hormone deficiency. Thank you. I would like to conclude my case with this quote that it is not just an itch. It is more than an itch, and those patients who are struggling with the itch, it is from the atopic dermatitis, should be thoroughly investigated and to look for other causes of atopic dermatitis and some of the causes that are associated with syndrome. So we as a dermatologist should acknowledge this fact that the aim of our treatment is not only to provide the relief of itch, but also to provide the diagnosis to our patient. Thank you. I would like to invite Dr. Madiha for her conclusive remarks.
Assalamu alaikum, everyone. I'm Dr. Madiha Sajjad. Thank you, Dr. Eraj, for the nice presentation. This case is basically selected to highlight and emphasize on the need of the maintaining a high index of suspicion and the need of the relevant investigations and continuous follow-up in a child who is born with severe erythrodermic ichthyosis, seemingly resistant atopic eczema, and associated hyper IgE level or any sort of skin infections earlier in the life or maybe later in the life, as this child has presented to us later in the life. As this could be the initial presentation in number of skin conditions like our case, Netherton's, Aman's, SCIDS, hyper IgE syndrome, both STAT3 and DOCK8 deficiency, and maybe many more. In the initial workup of the patient, we were also carried away by the diagnosis which was made for her uncle and even her elder brother. But later on, as we follow up this case, the clinical findings gives us very specific clues, and with the help of the immunological assistance, we were able to reach this diagnosis. Though we needed a genetic confirmation to label this diagnosis, but it wasn't easily and freely available in our setup. But trichoscopy has been a very accessible and a non-invasive diagnostic tool, which helps us to make a prompt diagnosis. So basically, this was a child who didn't present to us initially, but later on. And we were lucky enough to reach to this diagnosis and would try to improve her rest of the life along with her brother. So that's all from my side. And now I would like to invite Dr. Zainab, which she is going to present an
Assalamu alaikum. I'm Dr. Zainab Ali. I'm FCPS trainee at Dermatology, DUHS, OJHA campus. नहीं चल रहा है. Excuse me. Yeah. Assalamu alaikum. I am Dr. Zainab Ali, FCPS trainee at Dermatology Department, DUHS, OJHA campus. Today, I am presenting third interesting case of CPC, which is about 25-year-old female unmarried resident of Karachi with no known comorbid presented in our OPD on 17 January 2024. Her presenting complaint was single lesion on the left arm for 4 months. Her history of presenting complaint, according to patient, she was all right 4 months back. Then she developed single lesion on the left arm, which was initially small, then increased in size gradually. It was associated with mild itching throughout the day, but not abdominal pain or infection recently. No history of epistaxis, gum bleeding, GI bleeding. No history of discharge or bleeding from the lesion. No history of such lesion in other family members. Systemic review was unremarkable. Her past medical and surgical history was also unremarkable. Personal history was also unremarkable. Gynecological history. Her age of menarche was 13 years. She has a regular menstrual cycle and no history of dysmenorrhea. Her family history was unremarkable. And drug history, she used multiple undocumented medication, which was for topical use without was also unremarkable. Her socioeconomic history was she belonged to the poor family. So a consent was taken from the patient and her attendant for examination and also to share the pictures. A young female of good height and build sitting comfortably on the chair, well-oriented to time-plane person. She was vitally stable and sub-vitals were negative. Her cutaneous examination was, there was a single well-defined erythematous to bluish plaque with irregular margins. 2 to 3 bluish nodules were appreciated at the borders, measuring about 5 by 5 centimeters. Elbow. Surrounding skin was hyperpigmented. No scaling, no discharge was noted. On palpation, it was soft, non-tender, no temperature difference was noted. Other examination like mucosa, nail, and scalp was unremarkable. Systemic examination was unremarkable. Case summary, a 25-year-old unmarried female with no known comorbid resident of Karachi presented to our OPD with complaint of single erythematous lesion on the left arm for 4 months associated with mild itching. It was gradually increasing in size, but not in number. Cutaneous examination was single well-defined erythematous to bluish plaque with irregular margin. 2 to 3 bluish nodules were appreciated at the borders, measuring about 5 by 5 centimeters in size, located over the left arm just above the elbow. Surrounding skin was hyperpigmented. So on the basis of clinical feature, history and clinical examination, we made the differential diagnosis Kaposi sarcoma, leukemia cutis, diffuse large B-cell lymphoma, cutaneous T-cell lymphoma, and subcutaneous panniculitis, and also angiosarcoma. So now we proceeded for investigations, which are CBC. CBC parameters are parameters are within normal range, and peripheral phlegm is normocytic and normochromic. PT, APTT, ESR, CRP are within the normal range. X-ray chest, ultrasound abdomen are normal, and HIV serology is negative. Then proceeded for the skin biopsy, which show intact epidermis and dermis heavily infiltrated by sheet of the large cells. The neoplastic cell exhibit hyperchromatic nuclei with prominent nucleoli and scanty cytoplasm. Overlying grain zone is also appreciated. So the conclusion was neoplastic lesion. This is the neoplastic lesion. That's why we gone through the immunohistochemistry staining, which shows CD20 negative, CD8 negative. CD20 is marker for B cell and CD8 is marker for T cells. BCL2, BCL6 is also negative. These are marker for non-Hodgkin lymphoma and diffuse large B cell lymphoma. CD5 is also negative, which is a marker of T cell. TDT is negative, which is a marker of lymphoblastic leukemia. C-mice is also negative, which is a marker of B cell and DNA synthesis. LCA is positive, which is a leukocyte common antigen for hematological malignancy. Chi67 is 95%, which show the proliferation index, and CD4 is positive, which is a marker for T cell, and CD34 is positive, which is a marker for angiogenesis in the malignant tumors. CD56 is positive, which is a marker for NK cell. So on the basis of immunohistochemistry marker, clinical feature, and biopsy finding, we made the final diagnosis of blastic plasmacytoid dendritic cell neoplasm. Previously, it was called NK cell lymphoma, which is a very, very rare malignancy. So management, patient was counseled in detail regarding the nature of disease, and patient referred to the oncologist for the treatment. But patient came after 1 month back to us, and unfortunately, she did not went to the oncologist. And she presented with a deterioration of her clinical condition with general malaise, weakness, lymphadenopathy, and multiple petechial hemorrhages all over the body, bilateral conjunctival hemorrhages, and also bilateral conjunctival hemorrhages, and also petechial hemorrhages. The previous nodule was more darker. So we counsel in detail to the patient and attendant. Their prognosis is not better, and we accompany the patient to oncologist for treatment. Now the literature review. This is very, very rare case. So there are 500 to 1,000 cases worldwide reported. Few cases are here. One is from the Indian Journal, reported from the Pakistan oncology department. 11-year-old child presented with a single bruise-like lesion on the face, which was later on diagnosed as a blastic plasmacytoid dendritic cell neoplasm. And other one is from Indian Journal and reported in the India, which was a 70-year-old male and presented with a bruise-like lesion on the trunk. These are some from the different cases, mucosal involvement is in our patient. Now the discussion. Blastic plasmacytoid dendritic cell neoplasm. This is CD4 and CD56 positive hematodermic neoplasm. This is a rare hematological neoplasm, which is now thought to be derived from the blastic plasmacytoid dendritic cell, which was previously called NK cell lymphoma. So predilection for extranodal site, particularly skin, and tendency to leukemic dissemination. Epidemiology, there is a no racial predisposition. Elderly male patients are mostly affected. Pathology, a dense monomorphic infiltrate of medium-sized tumor cell with a fine chromatin resembling lymphoblast is seen throughout the dermis with a well-defined grain zone. Occasionally, tumor cells show roseate pattern, necrosis, and angiocentricity are usually absent. Immunophenotype, tumor cells are CD56 positive with variable expression of CD4, CD45, and CD43. The rare cases are CD34, 68, and TDT positive. Clinical feature, patient will present with a multiple and rarely solitary large mauve dermal tumor, which can become ulcerative. There is a no specific site predilection, but the upper trunk is often affected. Primary cutaneous disease is common, but the lymphadenopathy and peripheral blood bone marrow involvement is likely during the course of disease. Patient can present with cytopenia, lymphadenopathy, hepatomegaly, and splenomegaly. There have also been reports of involvement of mucosal membrane, as in our patient, tonsils, and paranasal cavities. Disease course and prognosis. The prognosis is very poor with a median survival of 14 months reported. The survival may be better in patient less than a 40-year-old and with a high TDT expression. Management. The targeted therapy, tagraxofus and hematopoietic stem cell transplantation and other targeted therapy are venetoclax, bendamustine and biweekly CHOP chemotherapy are other therapeutic options. Thank you so much. I would like to call Dr. Sadaf for her valuable remarks.
Thank you, Dr. Zainab. Okay. This was a really rare case, and we wanted to present this not just for academic reasons, but for awareness as well. As was mentioned, it's a rare malignancy in general as per se. But the significant part is that this rare malignancy presents with cutaneous marker. The cutaneous lesion is one of the identifying features. As was mentioned, this was CD56 positive. CD56 positivity means that the patient generally has a cutaneous lesion, which may be a clue to detection and diagnosis. And although very few cases have been reported otherwise, but the cases reported have been mostly with a cutaneous lesion, either mostly resembling a bruise, erythematous plaque, nodule, or a very non-significant rash as well. But if detected for diagnosis, then slightly better prognosis is there, although the overall is not a good prognostic element of this rare malignancy. If the patient is CD56 negative, it primarily presents with a hematological involvement, more severe, more aggressive. So being CD56 positive and having a cutaneous clue is a better element compared to being negative. Secondarily, as was mentioned, the cases reported have been by oncology department or pathology, but dermatological reporting has not been there. We have all these cases have been reported in journals, and this case is the first one which will be reported by the dermatology department by us in a journal, which has already been submitted. And we're thankful to the pathology department, our histopathology department, and our dermatopathologist who really thoroughly worked up this case along side by side, keeping us in close coordination so that we may reach a prompt diagnosis for this patient and direct her in the correct department and for the proper facilitation and care. So this was all for today. Thanking everybody once again, and our media partners as well, Mr. Yasser and his team. If there are any comments, we will surely take them. Madiha, you want to join in? Just take the chair.
I would like to appreciate if my voice is there.
Okay. Dr. Humaira, Dr. Zanaz was speaking.
Can I comment?
Yes, please. We can't hear you. She's mute. Unmute करें. Dr. Zanaz, we can't hear you.
Okay, sorry. Now can you hear me?
Yes, we can.
It was a pleasure, like getting such a comprehensive session early in the morning for me, a good dose. तो लेकिन ये जो है ना the Netherton का बच्चा, ये इसको बहुत ही अच्छा केस है for long case or short case at CPSP, चाहे MCPS हो चाहे FCPS हो. These cases should be registered and recorded because वहाँ पे एक pool बनाया हुआ है उन्होंने, so this must go into the recording. And naturally, the way that I think if that lady had gone early to the oncologist, it would have helped her. And I don't think so she would be there for, student workup or something of that sort. But it was good that the thought, and I'm really surprised and I'm really impressed by the marker studies. हमारे ज़माने में एक या दो CV होता था, वो भी बहुत मुश्किल से only Aga Khan was offering. I just want to know, where do you refer your cases for the marker study?
So madam, we get them done in our institute only. We have the facility over here. All the
Okay,
immunohistochemistry is done here only.
माशाल्लाह हम लोग तो पिलर्स एंड पोस्ट जाते थे, ये सब स्टडीज नहीं होते थे, हम लोग को मिलती नहीं थी. Like, this is a rare case and a very good presentation and a very good catch of the patient. And the best part was that you did not let the patient go away and you accompanied the patient. That is the empathy of the whole scenario. लोग जब देखते हैं ना कि सारा फैल गया है and terminal case है, then they abandon the patient. And as doctors, we should have this empathy in us, and we should show concern. And you guided and accompanied the patient. That was the best part of your presentation, as far as I'm concerned. I wish you all the best. The speakers, the presenters were very good, and of course, in your guidance, you all are doing a good job. I wish you all the best, and thank you.
Thank you so much. Your comments
You're
mean a lot.
You're welcome.
Okay, next. Okay, is there anybody else? Yes, Dr. Atiya.
Yeah, very well done. Congratulations to your team, to Dr. Sadaf, Dr. Madiha, and your wonderful team. You have really presented 3 wonderful cases.
Thank you.
Good learning experiences for our residents, how to take a proper history, a detailed history and examination, developing this, having a good clinical acumen, a list of differential diagnoses and how you rule them out. So that was really very well done. And regarding this Netherton syndrome, there are just a few case reports.
I think the 2 lines have interconnected. Yeah. Yes,
Yeah.
now please continue.
Yeah. And regarding Netherton syndrome, there are a few case reports where retinoids have worked, but then in majority of the cases, it have worsened the condition. So that's one thing that can probably be tried in lower doses. And if it helps, then the patient can be put on, because initially we would say that oral retinoids shouldn't be given, but then a few case reports came up like that. But a wonderful effort, and I must congratulate your efforts.
Thank you so much.
Thank you.
Dr.
Assalamu
Humaira?
alaikum. Can you hear me?
Yes, we can hear you.
First of all, I must congratulate DIMC for presenting such wonderful cases. All the cases were thoroughly worked up.
Thank
And
you.
I have a query regarding the first case. Why not congenital erythropoietic porphyria instead of porphyria cutaneous tarda? Can
There
you
were 2
explain?
Yes, we worked it up and we were thinking that maybe it was a milder version of CEP, and that is why we wanted the porphyrin levels to be done. Unfortunately, they could not be. That was one. Secondly, there was no mutilation. Whatever literature work we had read and studied and we were working, over a period of 11 years, some form of mutilation or some form of changes should have happened accordingly. Thirdly, because the erythrodontia was there, we did consider as a variant of CEP could be there. But then we had enough literature support where it emphasized that that could be a feature of PCT as well as CEP. So that is not something. So from the clinical scenario, the picture, the availability, and her great response to treatment and her improvement side by side, the thing went more in favor of PCT rather than CEP.
Okay, but CEP can appear early and PCT can appear afterwards also, no? And this patient
can
has
be both
presented
ways.
earlier.
PCT can present early as well as late as well. That was also, we presented 2 cases over there as well, in which one presented late and one presented early since childhood. So we had all of these, even hepatoerythropoietic porphyria, which is the homozygous variant of PCT, was also considered as a differential, and that also presents since early childhood. but that is again a more severe form and results with, again, features resembling midway between CEP and PCT. But considering her otherwise, her development, everything was otherwise normal. So this was more in favor. Again, as I mentioned, we still wanted to confirm
We
it with
cannot
profiling
confirm
studies.
because enzymes
Yeah.
are not available.
Yeah, because we really did try hard if that was a possibility, either the gene workup or the porphyrins, but unfortunately neither was available. Yeah.
Okay, fine. I must congratulate. Thank you.
You're welcome. Okay, Dr. Rima. Yes. And अच्छा जी 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 अस्सलाम वालेकुम
पता नहीं how
जी
I'm
Yes.
Dr. Yasmina Khan. Can you hear me?
Yes, we can hear you.
Well, I must congratulate you for this excellent workup of the cases. And you must look up your email, both of you, Dr. Sadaf and Dr. Madiha. Yesterday, I have sent them to you. And this is the World Congress of Pediatric Dermatology to be held in April next year. Every 4 years, they hold this conference, and you must represent our country, Pakistan, because so far I was the only one in 2013, and I was ashamed because they said you are the only one from Pakistan. So now I'm too old. Now you youth should go there, present cases. They have a scholarship for you, and if you read my 2 emails and any further inquiry, I will let you know. We must represent Pakistan at the World Congress of Pediatric Dermatology because we have more children than the European countries. And this is a World Congress. Every country of the world is there except Pakistan. And I was there on so every 4 years, this is the 15th. So 60 years plus, because you don't start a World Congress at once. First, you establish a society, pediatric dermatology was established, and then these Congress was started. So you must attend these, read my emails, and if further anything you want to know, you have to become member of International Society of Pediatric Dermatology. It takes 10 minutes, no fee to be paid, and then you register yourself, no fee to be paid. On 7th of September, there's a webinar. Every 6 weeks, they have a webinar. You just connect and you listen to it. So they don't want any money, but they want people. And I have been managed about 100 Pakistani doctors have become members of International Society of Pediatric Dermatology. And we should increase the number, and we should be the front line because we have more children than the European countries. So please read up my emails and then acknowledge them. And whatever you want to know, I'll help you further. And you must work. And they want to know who's going to be the next president, who will present for after 4 years the pediatric dermatology conference. So you have presented 2 very nice cases, and you've been doing in the past. So you must host this after 4 years. So 25 is the 15th, and then the 16th can be in Pakistan. So we must take our country forwards. So that's my message. And I'll continue giving you messages. So keep on reading the forum, pediatric forum, and the emails, which I sent from my laptop. Thank you.
Thank you. Inshallah.
Thank you. Inshallah.
Hello.
Dr. Madiha, you also read the email.
Surely I'll do. Thank you.
Yes, yes, Dr. Rima.
Assalamu alaikum. Congratulations, Dr. Sadaf, Dr. Madiha, and the whole team. Can you hear me, please?
Yes, yes.
Hello?
Yes, yes, we can hear you.
Firstly, yes, I want to congratulate Dr. Sadaf, Madiha, and the whole team of DIMC for presentation of such nice cases. I just wanted to ask, you just mentioned to Dr. Zarnaz that all these CD markers and all, they are being done in OJHA. So, do you have an idea how much do they cost on an average? And is there any provision for zakat? Because if we send patients from civil hospital, then they are not very they are non-affording patients. So,
Dr.
is there
Neha?
any?
Yeah, it's,
Yes.
I think all these markers are covered. I think it's 5.5, yeah, 6,000, okay? And
Oh, that's
all of
great.
these are covered in that. And I don't think there's a zakat system in the particular department, but in general, there is a zakat center in the hospital. How long they take, what is the processing thing, that takes time like any other institute does. But on personal basis, like if someone wants to help someone and they can arrange it, then it's just managed by the department. But like as I mentioned, if in the lab there is no separate zakat counter, but the hospital has it, they work up the patient just as that happens in any other institute with the NIC number, and they, whatever the process is, it takes time. But if there's something that has to be done, then normally we manage by contributing among each other, and that is how we just go on the rapid mode.
Okay, that's great. Asha, and do you have immunofluorescence?
We have immunofluorescence as well, and that is around the same cost as well. Direct immunofluorescence is there. No, direct. Yeah, we have direct immunofluorescence. Yes.
Okay, thank you. And congratulations once again. Okay.
Along with the biopsy, yeah. When we send them, we send the two samples separately, right? So with the total cost comes around 9,000 with the biopsy sample as well as the immunofluorescence sample. But if you need details, just contact me. I'll tell you how to go about it, because if you're sending an immunofluorescence sample, then we have to pre-inform the department before a particular time. And then we manage to send the samples ASAP before that particular time in correspondence with the person who's in charge.
Okay. Okay. Thank you so much.
Welcome.
Yeah.
Okay. That's it. Okay, so if that's all, then thank you everybody. And the good thing is we've managed to complete the activity within its designated time. So we're off to our work routine, and so does everybody. All the best. See you next time with the next CPC. Thank you. Allah Hafiz.